2026 Geriatric Competency Series. This is presented by the Josephine County Older Adult Behavioral Health Initiative, the specialists within the county. This is the light at the end supporting those facing their mortality with Susan Hedlund. And let me forward my slide. A few things just to let everyone know some training details and etiquette. Keep your mics muted. We want you to utilize the chat for questions and comments. We'll have time at the very end to have a more full, question and answer period, but we will answer questions during the training if it is urgent. And we will be following up with you with the slides, with any extra training materials that we discuss, the recording link that goes to our OABHI YouTube channel. And we also want you to know that you do have to attend today's live training to receive the 2 CEU credits. And we will also be sending a follow-up survey that's going to come from Portland State University. So I gave you the email address that it's going to be coming from. It's a little bit unusual. And they're going to send a certificate out for the evaluation. Okay, so just a little intro into the OABHI. So in 2015, the Oregon Health Authority launched the Older Adult Behavioral Health Initiative, and we have between 22 to 26 specialists across the state that are looking over different counties, and we are an amazing resource. So myself, Luisa Guardion, and we have a number of other older adult specialists in the training today. So go ahead and put your name and your county, if you're an older adult specialist, in the chat so that people know who we are. So great resource. We do lots of trainings. We do workforce and community education, and we offer complex care consultations for older adults that have behavioral health needs. So please utilize us. Go to our website to find out who is the persons in your county. Okay, and so I want to introduce Susan Hedlund, our trainer today. Susan has been a social worker in the healthcare field for more than 30 years. She has a ton of experience supporting individuals and families that are facing life-threatening, life-limiting illness and also loss. She is currently the Director of Supportive Care Initiatives at the Biller Family Foundation in Seattle. And she was previously the Director of Patient and Family Services at the Knight Cancer Institute at OHSU. So she's an associate professor at the School of Medicine at OHSU, and she is a graduate from the School of Social Work at Portland State University. And so she is a wonderful teacher, and just a fact, she was our very first Gero Comp trainer 4 years ago, almost to the date. So we are very excited to welcome her back and to learn more from her. So if you want to share your slides, you can go ahead and pull those up, Susan.
Can you see these okay?
Yes.
Okay, great. Now let me see if I can figure out how to get into the
presenter mode.
Here we go. There we go. Excuse me. First of all, thank you for such a kind introduction, Elizabeth. And I didn't quite realize until this morning that I'd been your very, very first speaker. The work you do is so critically important. And, particularly as our population continues to age, I just think there aren't nearly enough of you to really provide the resource that we need, because we just need more and more and more of it. And so thank you for the work you do. I know sometimes this work can feel lonely and can feel a little bit isolating, and particularly for those of you in really rural areas, it's just such a wonderful opportunity to get together in a network like this. And so thank you for having me. I want to say that this is not an easy topic. I should say that off the right out of the gate here, but I think it's an important one. And something that I would also say is that I've heard it mentioned that we're one of the only cultures in the world that views death as optional. And yeah, the truth is, all of us someday will have to face our own mortality. And that's part of what I want to talk about today. And particularly for older adults, that reality becomes so much more palpable as aging happens. So I'll talk about that today. And as Elizabeth said, please put comments or questions in the chat, and we'll have ample time at the end to talk about some of that. Nothing to disclose. I'm not saddling up to a pharma company or anybody like that. But I do want to talk a little bit about what we hope to consider in this next couple of hours together, to talk a little bit about the fear and the vulnerability that is experienced by older adults who are facing death. And I would add, it's not just older adults. I think anyone facing death has an experience of fear and vulnerability. To talk a little bit about some of the approaches and techniques that we've learned can be really helpful toward the end of life. But I want to make it really practical, so that whether you are well trained in the counseling and psychotherapy field, or you're in more of a case management role, hopefully you can take a few things from what we talked about this morning and apply it pretty directly and immediately to your work. So we know that we are getting older. The silver tsunami is real. The baby boomers are aging out. I was just in preparation for this talk today, I was reading something yesterday that suggested, excuse me, that we're actually going to peak, but not until 2080, and I'll be long gone by then. But there will be a leveling out of this aging boom in the 2080s, and that the article I was reading suggested that'll be true internationally, not just in the United States. But in the meantime, we are challenged to create systems of care that adequately care for our elders as their needs become greater. There's a PBS documentary that I used to show in one of my classes called Living Old, and it's really well done. It's pretty dated. I think it was done in the 90s now, but or early 2000s. But it just talked about the challenge of, we are aging, we're living longer, in part because of advances in medical care, but our systems of care, and I know I'm singing to the choir here, they haven't necessarily evolved to support all of the needs that are there, particularly for people who are more isolated and for people who don't have a lot of financial resources. Our options are much more limited. The Pew Research Center, which is a group I follow closely because they do a lot of really wonderful research of the general population, and they tend to be pretty unbiased, which I appreciate, especially in this era that we're living in. But this was a study that they did last year of about almost 9,000 older Americans, and they asked, based on your own experience, what advice would you give to help younger people prepare for aging? And this was their advice: enjoy life, have gratitude, be true to oneself, and help others. I really loved this list. I thought, okay, this is simple. It's straightforward, and it's things that I think, at the end of the day, are things we could all take some lessons from. I think this came from people who were older. That same study looked at what elderly adults were worried about. Not surprisingly to probably any of us, number one was finances. Number two, will I have enough money to live however long I'm going to live? And even when you talk to health actuaries, nobody can exactly predict how long we're going to live. And when I work with people with advanced cancers, which has been my specialty, I often hear the question, should I just blow all my money and go live my life and do all the things I always wanted to do? But then if I end up surviving, and they have these breakthrough treatments, then I won't have any money left, and that crazy juxtaposition of, how do I balance that? Um, Loneliness. We certainly, the pandemic revealed this enormous culture of loneliness that we experience in the United States. And our former Surgeon General wrote a book called Together, in which he talked about this whole crisis of loneliness in our culture. And I think that is particularly true for many older adults who may be living alone, may not have extended family or family nearby. Not surprisingly, control over physical health, mobility, mental sharpness and acuity was another concern. And interestingly, on this list, mindset showed up. And I was thinking about, I have two elderly people that I work very closely with. They're both in their mid 80s, they're both women. Both were fairly well educated. One is a retired minister. And she says to me almost every time that I see her, I really thought that I would just die in my sleep with no physical impairments and no cognitive decline. And I think that's sort of the fantasy that we all have. But she also is, it's been really interesting for me to work with her as a retired minister. Her mindset is probably among the most negative that I've ever worked with. And I think I mistakenly assumed, having been a minister, that she might not have a negative mindset, but she does. Compare her to the same another woman that I work with who's also 85. And she is the most optimistic person I've ever met, other than my dad. And, she just lives life with gusto every day, despite the challenges, despite the limitations. So mindset's a really important one. And, I think that that's a really significant variable and can be either a protective factor as we age or not, depending on one's perspective. On this list was also relationships, being able to pursue activities that are meaningful, being able to do some sort of work, and I don't necessarily mean that as employment, and then faith. And many of you may be familiar with the blue zones, which are areas in the world where people seem to live and live well, well into their 80s and 90s. And interestingly, the variables that are included in that group are a sense of community, faith, work, and what else is there? Mindset as well. Oh, and lifestyle, which includes healthy eating. Elizabeth Ekstrom, who's a geriatrician at OHSU, took a sabbatical and visited the blue zones. And one of the things she said to me was how terrified she was seeing 80-year-old men going up ladders in Italy to pick olives, or in olive trees. And yet that's what they had done their whole lives. And so for them, that was continuing their meaningful work. So just something to think about, how can we continue to do things that are meaningful? The Johnny Hartford Foundation is a group that I truthfully didn't know much about until I took my current job, but they are a foundation that really works to support initiatives specifically for healthy aging. And one of their recent studies reflected, not surprisingly, dissatisfaction with the healthcare system that was very prevalent among older adults. Also, that many many needs in the United States for people 65 and older go unmet. The challenges are worse for, of course, underserved areas and populations. That shouldn't come as a surprise for any of us, I don't think. And that the need exists to create what they call age-friendly health systems. Also, they really highlighted two critical needs for those who are aging: social isolation, and then assistance for family caregivers. I was at a conference recently where the AARP and the National Alliance for Caregiving reported on their most recent study about caregivers, and the number of people providing care for loved ones is exponentially growing, and yet we lack support to adequately take care of the caregivers as they support their aging or otherwise impaired loved ones that they're needing to take care of. So, I think we're going to see more and more about the need for caregivers, but again, social isolation. And I know one of the projects through, I believe it's your program, Elizabeth, about the loneliness helpline, that is a really important part of making sure that people have a place to call if they are needing that. And then the Johnny Hartford Foundation also funded research that created what they called the four M's in assessing needs for the elderly. And we've really incorporated this into many of our medical practices. The first M is what matters to you? And that's, in healthcare, we get so obsessed with treating symptoms and treating diseases that we forget to sometimes talk about what's really important to you. Is it your quality of life or is it quantity of life? Then certainly looking at medications, how many of you have worked with elderly adults who have had several different prescribers throwing different medications at different conditions, but nobody's sorting out, are they working well together? And no wonder people come to us with these pillboxes, feeling really confused about what they should be taking and what works when and that sort of thing. Mind and cognition, of course, that's a really important thing for many of our aging clients. And then mobility. We know that fall risks are a big risk for elderly people and can often signify a significant decline if somebody falls. So those four M's, what matters to you, medications, mind and cognition, and mobility. So shifting now to thinking about the end of life, again, I think this isn't just specific to our aging adults, but I think it's also true for all of us. Most of us would prefer not to think about this. And I think that's just fine. I mean, in many of my patients who over the years, are facing the end of their lives will tell me that that isn't the first thing they want to think about when they wake up in the morning. They would rather think about other things because it's scary. There's so much mystery. There's so much unknown, even for people who seem to have made peace with this. But again, this is a tough topic. So some of the things that I think are important to think about when we're working with someone who is facing either a life-threatening or life-limiting illness are, or just truthfully, the declines of aging. It's dealing with physical, psychological, social, financial, and spiritual aspects of illness. So it's really across all of those domains. It's not just the physical decline, but it's also psychologically. Many people experience a lot of anxiety or depression, or anhedonia of just feeling, just really struggling with what's happening. It can be very isolating. It can impact our social relationships and certainly can be expensive as well, even for people with good insurance. Lots of ongoing fear and anxiety, including fear of death, examining life and lifestyle issues, and constructing one's own story. I have a very dear friend who's a retired pediatric oncologist, and we get together periodically to share a glass of wine and share stories. And he said to me the other day, Susan, I'm not afraid of being dead. It's the process of getting there that's scary to me. And that is fairly universal for most of us, that certainly there are those who fear what's on the other side, if there is another side, and the mystery of all of that. But it's more what's going to happen to me along the way. And will my symptoms be managed? Will I be able to tolerate that? Will my family be able to tolerate that? The other thing is some diseases, even certain cancers now have become chronic. And certainly the neurological diseases, chronic obstructive pulmonary disease, they have periods of remissions and relapses, and that can go on for a long, long time. I have a brother-in-law who has very, very advanced Parkinson's, and the remissions and relapses for him are really significant. And it requires everybody adapting to those changes. And it also requires, I think, for anybody who cares about these folks with these illnesses, as well as the patient themselves, longer periods of anticipatory grief. The sadness of losing your loved one kind of by millimeters in a way. And for some diseases, my mom had Alzheimer's disease for 7 years. And so it was like losing her through little increments. And it was this long, long period of you'd occasionally have a window that reminded us of who she had been before, and then she would go back into her dementia. And so, with that comes grieving. You lose the person before you actually lose the person with many of these diseases. And again, increased financial, social, and physical pressure, long-term family disruption, progressive declines, and sometimes dilemmas about decision making and treatment. How much more do I want to do here? Is it time for me to shift into palliative or comfort measures or hospice, rather than continuing to try to pursue more aggressive treatment? And that's different for each person we work with and the context in which they're living with their illness. We also know that as people face the end of their life or loss of hopes for recovery, lots of issues arise, including their awareness of dying and mortality. So again, most of us would kind of prefer to avoid that if we can. But as death approaches, it's harder to avoid that. And so, it brings up all kinds of issues of faith. It brings up issues of, what happens beyond this life. It brings up issues of, gosh, did my life matter? Did I do what I wanted to do in this lifetime? As well as wanting to preserve some modicum of autonomy. How much independence can I still hold on to? And we know, and you know better than I do, as you work with elderly adults, sometimes, holding on to that independence becomes a point of tension with family members. Think about all those conversations about taking away car keys, that last vestige of independence when it's not safe for that person to drive anymore. And yet that's that one thing that they feel like they still can do. And families are worried very much about the safety of that. Spiritual and existential needs, and gradually withdrawing from life and those that they love. Other tasks are dealing with symptoms, pain, discomfort, incapacitation, managing health procedures, and dealing effectively with caregivers. I think this is one we don't always pay enough attention to. And by caregivers, I'm referring to both family caregivers or in the instance of people who are living in either skilled nursing facilities or assisted livings. They have a lot of relationships that they have to maintain. And that isn't easy, and I remember when I directed a home-based palliative care program for a while, one of the issues that often came up for people living in assisted living is that they're not supposed to lock their doors at night. And, so that caregivers can enter their rooms. And that for some people, that was an issue. I don't want people to have easy access to me 24 hours a day. And yet, part of living in assisted living is to kind of create that sense of safety. And so, I think that dealing effectively with caregivers is an issue. And family caregivers, you've got not only the caregiving and the role changes, but you've got previous history relationships that may or may not be the most functional or the most, open communication, and with all the history that comes with that. Also, people have to prepare to say goodbye. We may be preparing to say goodbye to the person who is at the end of life, but they're preparing to say goodbye to everyone. And how do you do that while also preserving a sense of self and relationships with family and friends? And importantly, many, many people want to try to find meaning both in their living and in their dying. I sometimes tell a story of my next door neighbor's dad who was dying of a stage 4 glioblastoma brain tumor. They were caring for him at home, and it was a complicated situation because he'd been out of the family for a long time. He was an alcoholic. He, wasn't necessarily very involved with the family, and then he had this devastating diagnosis, and his wife and daughters decided to try to care for him at home. And on Wednesdays, I would go over and feed him and sit with him, not as a social worker, just as to give them respite so that the wife and daughters could go have dinner and take a few hours off. And I would sit with him, and it happened to be baseball, the World Series. And I grew up watching baseball with my dad. And so I could talk to him about baseball, and that's what we were talking about. And in the middle of this game, he looked over and he said to me, again, I wasn't there as a social worker, I was just there to be supportive. He said, "Do you think my family will remember me? Do you think my family will forgive me? Do you think they will know that I loved them?" And I was so shocked that he was asking these questions. And I tried to redirect it and say, what do you think? And we had kind of a really deep conversation, given that we were in the middle of baseball. And I asked him, do you think you can say these things to your family? And he said, well, I'll sure try. And I said, please do. I think that's really important. And then I, at the very end, said, if you end up not talking to them about it, may I share this with them? And fortunately, he said yes, because he died before he was able to have this conversation. And the night that he died, I went to their home and I shared all of this with them. And they all just sobbed and sobbed and sobbed because, again, he'd been pretty absent and he'd not been the greatest husband or father. But that was really important for them to know. Now, why did he share it with me? I think it's because I was safe. I think I was much safer a person to have that conversation because I was more or less a stranger versus really coming clean with these people that were important. But I use that as an example of, for many, many people, they want to feel like their life meant something and they want to have meaning both in living and in dying. For some people that's a pretty extreme example, but some people want to make sense of their dying so that they feel like their family can go forward. And I'll talk to people sometimes who will say, I really want to make sure that my family is safe, that maybe that on the other side of this, they can maintain close relationships, whatever it is that may give them a sense of meaning. At the end of life, people face issues that are not amenable to change, meaning if they're facing the end of life from an incurable disease, they can't necessarily change that or fix that. And so problem solving becomes different. And there have been a lot of studies done comparing Viktor Frankl's work from his book, Man's Search for Meaning, looking at concentration camp survivors and comparing it to people with cancer, that what Frankl wrote about is that when you can no longer change the facts of what's happening, then people sometimes look to change the sense of meaning about it. And so that's been compared to people with cancer who, in the beginning, they may hope for cure. And as the disease progresses, they may hope for resolution or hope for a better future for their families after their death occurs. So one of the things that I've been fascinated with my whole career is the role of hope. And I think that nurturing hope is a strategy that can help allay anxiety and depression or fear in situations where patients have very few direct problem solving options. And again, going back to Frankl's work, it's hoping for something different. So in the beginning, you may hope for a cure, and when that's no longer possible, hopes may change. They may shift to hope to live a little bit longer, hope to have a better night's sleep, hope to have better pain relief, hope to stay alive long enough to see a grandchild born or a grandchild graduate from college or attend a wedding. And there's some interesting literature in the hospice literature that talks about how people will maybe hold on for those specific events. We haven't been able to prove it, but people who work in hospice will tell you it sure seems true because people will maybe make it to that graduation or that grandbaby's birth and then let go. And I'm sure some of you have seen that in your own clinical experiences. So other themes might be, being discharged from the hospital, for those of you working in the community, regarding the illness itself, hope that maybe my symptoms will be better managed. Again, attaining specific goals. And most people want to be treated with dignity. Even if they're pretty impaired, they want to be treated with respect. They want to be treated as somebody who has an opinion and a life. There's a lot of times we hear people say, why did my caregiver keep calling me sweetie? And I think that when caregivers do that, it's with the best of intentions, but sometimes it doesn't land as well as it might, with people who, have had a very full life and who, still feel like they have a lot of things to give and want to be treated with dignity and respect. Hope themes may have religious or spiritual connotations. Did I live well enough that I can die in peace, feeling like, you know, um, my if judgment day comes, I'll be in a good place. I've worked with many people who have gone away from their faith practices for a range of reasons, only to feel like, uh-oh, I'm at the end of my life. And an example I'll give of that is a woman that I worked with many years ago, actually, when I was a brand new baby social worker, which was long, long ago. And the woman that I was working with was in her 60s. She was diagnosed with a blood cancer that was not curable. She had been a very, very devout Catholic until her 5-year old was killed in a playground accident. And very tragic, long time ago. And when her child died, she just turned right around and said, if that's what God allows to happen in this world, I'm not sure I believe in a God, and particularly in my faith. And then as she faced the end of her own life, she became really frightened about the decision she had made. And that became a source of real distress for her. And I was working in a Catholic hospital at the time and working with this absolutely wonderful nun who I felt could be a source of support for this patient. And so with her permission, I introduced the two of them, and Sister Kathleen was so lovely and just said to this woman who was really worried about having turned her back on her Catholic faith, Sister Kathleen said, I think your God would understand why you made that choice. It was a terrible time in your life. It was a terrible thing. And, and thankfully, this particular beautiful nun was able to support her through the end of her life. And she was able to make peace with the faith that she had turned her back on. And, I think that's not unusual for people, that they may have felt really good about walking away from whatever they were raised with, and only to find themselves at the end of life going, I wonder what I should do with this. And so, reconciling spiritual issues can be really important for some of the people we work with. Sometimes people really hope to continue to live and not die. Certainly, people have a lot of hope around the circumstances of their death and dying, and what will happen after they die. And other people really want to die. I remember working when I was with hospice with a 103-year-old person who every time I go to see her, she'd say, Susan, why am I still here? And of course, I didn't have a good answer for that question. But sometimes people are ready. And sometimes people will express a readiness to die or a desire to die just because they're kind of done, with all of this. And I think it's important to remember that desire to die statements doesn't necessarily mean that they're suicidal. It may mean that they're ready or they've made peace with it. My 93-year-old dad, before he died, said, I've lived a great life, and it's not that I'm in a hurry to die, but if I don't wake up tomorrow, that's okay too. And so I think we need to assess those statements and see what they actually may mean. People also worry about further debilitation and dependency. People, in our culture in particular, don't love being dependent on others. Of course, they worry about pain and suffering. How will their families survive? Arranging affairs and preparing for an uncertain future. Some people fear dying alone, others want to die alone. We make an assumption that people don't want to die alone, but I've worked with plenty of people who wait for the 1 second that everybody leaves the room and then they let go. And so we have to remember not everybody. We often die the way we live, and I think that's an important thing to remember too. But people fear losing control, changing relationships, and as I mentioned, some of the existential concerns. This is a very old quote, but I think it's interesting. The death of the self has many possible meanings. It can be viewed as an ending, as a beginning, as a transition or rite of passage, or all three. It can be viewed as a reward, a punishment, or a partaking of both. And it can be perceived from a base in which a series of losses develop. Loss of self, loss of people, loss of competence, loss of capacity to complete plans and projects, loss of body, loss of things. And then this one also is the human problem. Having a mind, being a body is nowhere quite so painfully and clearly apparent as in medicine. Painful because to be a body means we have to die. And um, uh, and also we having a mind means we know this. So that's sort of a dilemma, right? It's like my patient who said, I just thought I'd go to sleep, with no physical or cognitive impairment. When I worked in an oncology clinic, I did a death fantasy exercise one time with our doctors. These are all oncologists. And took them through a guided imagery of imagining the most perfect death possible. These are oncologists, and all of them, there were about 20 of them, wanted to die at an old age with their bodies and minds perfectly intact. And that isn't how it happens usually for most of us. I mean, it's nice if that happens, but most of us, as we age, our bodies decline, and often our minds do as well. I would add my very dearest friend, who is an oncologist, added with a perfectly clean house. So, think about how you might want to die, because I think that there are very specific circumstances. Truthfully, most of us don't want to die in an ICU. Most of us would prefer not to die in a nursing home or a hospital. But we only have so much control over some of these things. And so that's some of the existential angst around some of that. So quieting the mind, now this is one that I thought long and hard about taking out of this presentation, because I'm not 100% sure I buy this, but I'm going to show it to you anyway. It says people who are not afraid of dying are people who have tamed the mind, actually practice letting their mind rest with great equanimity. Then when they die, they can do that, and it gives them a chance to rise above their karmic disposition, and rise above their helplessness. I can't quite see all the words because of our screen. This is true for people who have done great meditations in any of the religions of the world, be it Catholicism, Judaism, Buddhism, Hinduism, whatever. I hope that's true. What I often will say to my colleagues and friends is, having worked with end of life issues my entire career, I don't know that I'm going to do this with much grace. I want to, I hope so. But I fear, my dear colleague in Boston and I have this joke that we fear we're going to be those cranky people hurling our scrambled eggs at our loving caregivers. And if I'm mad and one of you are one of my caseworkers, support people, I'm really sorry. I don't want to be that person. But I guess the reason I share that example is I don't think we have a guarantee, even for people who have great meditative practices. I don't know that it's 100% sure, how we will be until it's our turn. Till it's our turn. So none of us know, most of us don't know when or how we're going to die. And there remains fear, curiosity, and I think for some, a sense of wonder about what death is. I teach a class for first year medical students on living with life-threatening illness. And the best part of the class is we recruit patients who are at the end of their lives to visit with each of these medical students on an individual basis. And their role is just to get to know them. And every year we get the feedback that the students feel much less afraid of working with people at the end of their lives as a result of that experience. But I think one of the things that we do right out of the gate, the first day of class, is we ask these 16 first year medical students, what do you think happens when people die? And you can just see that look of terror in their faces. And each year is a little bit different. We've got last year, it was very interesting because we had a really interesting mix of people demographically, ethnically, and spiritually. So we had a whole mix of reflections based on their upbringing of Christianity, Judaism, Buddhism, Hinduism, or the other half of the class that was just, pure scientists, ashes to ashes, death to death. But we as faculty talk about what we think too. And so we try to make it safe by sharing what we think. And I think at the end of the day, most of us land in a place of a little bit of mystery. We have beliefs about it, but we won't know until it's our turn. So remember that each of our patients and loved ones, the people that we work with and their loved ones, will have their own thoughts about this, just as we do ourselves. So how do we support those facing death? I think one of the basic things we can do is promote life review and legacy making. And I'm going to present to you a few different models that we know are really helpful with working at people at the end of life. But I also want to reassure you that even if you don't go into a deep dive clinically with some of these models, every single one of you have the skills to support people through the end of life by simply being present. And I'll talk a little bit more about what that looks like. There's a what am I trying to say? There's a practice called creating a living will, or a story of one's life that can be helpful. And it's as opposed to a will where you designate where your belongings go or your finances go. A living will is more about what do you want people to remember? What's a lesson that you've learned that you like like the a Pew study, enjoy life, be open, be curious, be grateful, help others. What are the kinds of legacy leavings that your patient or person you're working with wants to leave behind for their loved ones? What's the thing you're most proud of, for example? What's something your family doesn't know? I have two friends who have recently lost their mothers, and both of them said spontaneously, I wished I'd asked her more questions about what it was like to grow up when she grew up. And we know some of those stories, but we don't necessarily know all of them. So promoting legacy writing or living will, photos, videos. There are lots of little groups out there these days who will do kind of videography at the end of one's life so that people can leave a video for their families. And those can be super meaningful. I've done that a lot with young parents who are dying and want to leave a legacy for their children so that they have a sense of who their parent was, as the child grows up. There's a whole movement out there called narrative medicine, and basically, at its basic, it's storytelling. And what we know is that narratives or stories about the same events can change over time and are influenced by the context in which they're told. I remember both of my dad and a couple of my uncles were World War II veterans. And back then, they were encouraged not to talk about the war when they got home. They're encouraged to just bury it and not talk about it. And I remember learning a lot about my uncle when my nephew came in with I don't know, it was like a G.I. Joe doll that was dressed in Army paratrooper gear. And my uncle just started talking about the war very spontaneously. And my aunt and cousins were shocked because he'd never spoken about it before. And I don't know what it was about that particular moment in time that gave him the permission and safety, but he told a lot of stories. And you see that at the end of life with people who may begin to tell stories that they've never told before. And families may have the privilege of learning about some of those things. But we also notice the reason that narrative approaches have become really important in psychotherapy, for example, is that the development of a sense of self occurs through the creation of stories, both in the privacy of self reflection as well as in our historical context, like in my uncle's case. When I had a private counseling practice, I often examined the stories that people told themselves about identity and started to look at where did that story come from and does it still fit, because sometimes people grow up with stories of real shame and they don't serve them very well later as we develop our lives. And so working to kind of reframe those stories can often be very helpful. And working with illness, I often would ask people to tell me about their illness and why they think, or how it makes sense to them, and not so much about why it happened, but how do they make sense of it. So for example, I worked with a young woman who had a very advanced cancer, and I said to her, what are you telling yourself about having this advanced cancer at such a young age, which is a different question than why do you think this happened. And what she said was, I said, what are you telling yourself? She said, I'm in an abusive marriage and one of us needed to die for it to end. Whoa, that was intense. That was so, so powerful and so important for us as a treatment team to know that, because then we worked with her differently. She ended up living a much longer time than any of us expected her to, but we almost became her extended family as a treatment team as she managed to leave that abusive marriage. But here was navigating this very aggressive illness. So it's one of the ways of finding kind of an archaeology sometimes of hope in their experiences. And at the end of life, these unfolding stories can bring about some epiphanies, and meaning that people can find some aha moments, even as they're navigating end of life and certain illnesses. I mentioned earlier that many people really want to develop a sense of meaning in both their living and their dying. And that sense of meaning is often grounded in their core beliefs and values, their cognitive meaning, again, the story that they're telling themselves about all this, affective or emotional meaning, and again, sometimes transcendent or spiritual meaning. Some people will say, I think God gave me this experience because I could handle it and it would help my family grow. And again, it's really important to listen to what our clients are telling us about their story rather than necessarily what our assigned meaning is. I think that's a really important thing. And all of you know this from the work you do. It's not up to us to answer their question about why is this happening, but for us to support them as they examine that question for themselves. So again, clarifying patients' perceptions is really important. Sometimes depending on the role that you're in, you can help improve communication skills with providers, by helping them script questions that they might have. I gave a talk the other day for a group called the Ovarian Cancer Alliance, which is a group I do their monthly support group. And a patient came up to me and she said, or a woman in the support group said, my doctor said that I should take a break from chemotherapy because of my fatigue, but I'm so scared to do that because what about my disease coming back? And it gave me an opportunity to say, well, a couple of things. Cancer treatment isn't always a precise science, and sometimes we give people breaks just so that their bodies can recover. But I'd encourage you to tell your doctor that you're scared about this. And she said, oh, I can do that. And I said, yes, you can. This is your body. This is your life. This is your treatment. Other things that we have learned are really helpful in working with people with serious illnesses, cognitive behavioral therapy. And for those of you who are familiar with that or trained in this, it's a specific approach that tries to help regulate emotion by bringing in thought. And so if somebody's extremely anxious, one of the things you can try to do is teach skills to help regulate that anxiety, some of which is to come back to the moment. That's where mindfulness approaches can really be helpful, because when we're anxious, we tend to have a physiological response that is fight, flight, or freeze. Our adrenaline goes up, our cortisol gets a push, our heart rate goes up, our breathing rates get more shallow. And we tend to be either really ruminating about the past or worrying about the future. And both of those things take us out of the present moment. So if we can help people who are really anxious self-regulate, and even if you don't have training in cognitive behavioral therapy, what you can do is help people breathe. Just take a minute to take a deep breath. Practice breathing with the person, which can often bring that down, and that brings people back to the present moment, which is why meditation techniques can be so helpful. Acceptance commitment therapies gained a lot of popularity in recent years, and that is a combination of cognitive behavioral therapy with mindfulness practices. And the reason that that's combined is, again, remember, people at the end of life, can't fix necessarily or cure their own illnesses. So finding a way to come back to the present moment with mindfulness and acceptance can be really helpful for people in that situation, as well as some of the techniques to help regulate emotion. And then as clinicians, we're challenged to balance reasonable optimism with the reality of the patient situation. We often hear people with serious illnesses tell us that their loved ones are telling them just to think positively. And that's with the best of intentions, but it's often not that helpful to the person who is sick. But what's more helpful is, to be present. And I was mentioning the role of hope. as case managers, as clinicians, we can still ask what people hope for. And again, those hopes may shift over time. Many people realize that their physical situation is changing, and that they're probably not going to be cured of their disease, but there's still room for hope. And so you may want to ask them, what are there things you still hope for? And there may well be, depending on what the person's situation is. So, talking with people who are terminally ill or at the end of life, first and foremost, and again, I know you all know this, so this isn't rocket science. Listen to what your patients say and what they want to discuss. It may be really deep and very profoundly existential, and it may not be. It might be, who's going to take care of my cat when I die? Who's going to take care of my garden? And the other thing that I tell my graduate students and medical students a lot is, don't assume your patient's fragile, because they may not be. But that's part of your good assessment skills coming in, particularly with our more articulate questions. You can explore many important topics and ask direct questions. But if this is kind of new to you, it can be scary. I will never, ever, ever forget the moment that I had a patient. I was doing a home visit with a physician. This was years ago. The patient looked at both of us and said, "Am I dying?" And he was, of course. The doctor froze. And and I'm again like a baby green social worker thinking, this isn't my role to tell them they're dying, but somebody's got to address the question, you know. And so something palliative care people will say a lot is, I hope that isn't so, but it looks like you probably are near the end of your life. And again, you don't have to be a doctor to say that. If people are asking, they want to know and they want somebody to answer it directly. But what you can do is say something like, it sounds like that's on your mind. Can you tell me more about that? Are there specific things that you're worried about? Are there things that we need to help you ask your doctor about? You don't have to be the doctor or the hospice nurse to do that. I don't know why I want to tell you this story, but I was walking my dog yesterday and I came around the corner and these two lovely young women sitting on the curb having a conversation. Of course, the Labrador that I have wanted to go greet them. And I was trying to kind of pull him back, and they happily engaged him. And I saw that they both had name tags on from a health system. And I said, "Oh, are you nurses?" And one was a nurse, one was a social worker. And I said, "Oh, where do you work?" And they said, "Oh, we work everywhere." And by that question, I knew they were hospice workers. And I said, "Oh, do you work for hospice?" And and they said yes. And we had this lovely, lovely, lovely conversation. But what I could tell was that they were debriefing the visit that they had just had. And of course, I didn't ask them about that, but I could tell that's what they were doing. And again, you can explore a lot of important issues with your patients by asking direct questions. They will guide you. They will tell you what they want to talk about. And if they don't want to talk about it, you will figure that out very quickly. But again, I think it's important to not assume your patient's fragile. So these are some just examples of things that anybody can use, when you're visiting with somebody who has a terminal illness. What's this been like for you, physically or emotionally? What's been difficult? What gives you strength? Have there been other tough times that you've had to face in your life? Have you been thinking about dying? Again, if they're not ready to talk about that, they won't. What worries do you have? And those are some things like, what's this been like for you? What worries do you have? Those are some more generic questions that you can perhaps go enter the story with. Have you discussed any of these with your family or other loved ones? For example, if someone says to you, "I'm really worried about how my family is going to do after I die," you might want to ask, have you asked them about that? And are there specific things you're worried about? Are there things you want them to know? Are there things you want them to remember? And what's most important to you now? Now, again, there will be some patients who are going to go raging into the night and are not going to want to face dying, are not going to want to acknowledge their decline. But then there are many others who will, and there's certainly family members who might be wanting to talk about that. Do you have preferences that you'd like your family and loved ones to know about? Have you completed an advance directive? That's a really important one for to guide families in what they might want. And how do you want to be remembered? I love this question. I love this question because most of us can think of something. At the end of the day, if this were my last day, how would you want to be remembered? I want to be remembered as kind. I want to be reminded as reasonably helpful. Some of the things that, and I invite you to think about that question. How do you want to be remembered? And are we living our lives in alignment with that? And again, that's an opportunity for review or for legacy work. And you don't have to be trained in a particular therapeutic approach to do that. I think another thing that's really important for all of us to remember, and this is again, I talked to graduate students about this, but you guys are skilled clinicians. I still think at the end of the day, it's important to remember to listen attentively. One of the things, having worked in an acute care health system, there were so many distractions constantly that it got in the way of really listening. And one of my favorite physicians used to use there were flags outside of the exam room doors. He used to flip it over as a reminder of himself to turn off his pager and show up and be completely 100% present with his patient so that he wasn't distracted by a pager. He wasn't distracted by, all the calls he needed to return. He wasn't distracted by the chart notes that he hadn't done, but was there really listening. And it doesn't have to take more time. But I think, again, you may want to check where you are going into your visit with your clients. Take a few deep breaths yourself and be really grounded. Because again, if the more calm we are, the more we can help ground the person that we're visiting with. As I mentioned, it's really helpful to try to keep the person in the here and now because when we're anxious, we tend to be in the past or in the future. And that's different. I mean, if people are doing life review, then that's a little bit different. We want to hear what happened to them before and what's important to them. But we also may want to slow down a little bit and encourage people to talk about what they're worried about and then normalize their experience by just simply saying, it makes sense that you're scared about this. It makes sense that you have some worries here, and how can we talk that through? I've learned a long time ago that it's really helpful if you can help your client name their worry, get really specific about it, because it may or may not be something you can help ameliorate. So if they're really worried about pain, you may be able to talk with their providers or whoever it is that you're interfacing with to say they're really worried about it. When I was working in a hospital-based system, sometimes patients wouldn't take their pain medicine as prescribed because they were worried that they'd run out of options and it would get worse. And I was able to do a whole lot of education about that and then bring in their providers to say, we need to talk about this, but it might be something that you're not even thinking about. What are you most worried about? I'm worried that my kids won't be able to handle this. I'm worried that my spouse, can't handle this. And it may open the door to some problem solving that you can help with. But again, often being really specific about what they're most worried about can really be helpful. And then, of course, this is obvious, but being compassionate and empathetic, which all of you are, respectful and non-judgmental, being genuine and authentic, being trustworthy and fully present. And that I really come back to this because we're living in an era where things are so contentious and we're in a culture that is pretty divided right now. And we may be working with clients that don't share some of the values and beliefs that we have. Nonetheless, I think showing up in a genuine and respectful and authentic and respectful way can be so, so important. And again, I think I love the concept of therapeutic humility. We don't know everything, right? We're human too. And I think you know how to do this better than some practitioners do. You know, physicians often get very terrified when a lot of emotion shows up in the room. But I think those of you who do this work are more accustomed to managing emotion as it shows up. So not avoiding emotion, tolerating ambiguity. Okay, that's a tough one. That's a tough one. And by ambiguity, I mean you can't guarantee that this person is going to survive. You know, they probably are facing the end of their life. And so, you know, being able to explore those hard topics like end of life, accepting and honoring the patient as the expert in their own life, and being a catalyst for therapeutic change. And what I mean by that is by telling their story, they may have an opportunity to kind of reauthor that story and have it turn out a little bit differently as they shift their own narrative. And being present. This isn't a fabulous picture. The guy leaning over the bed is a photographer. I had a chance to actually be part of a little musical group that sang at Hopewell House, and this gentleman, a Scottish gentleman, sang every word to every song. And I later learned that he was at Hopewell House here in Portland, and he kept his door closed the entire time, which is unusual. But he came out into this beautiful patio and garden for the music and sang along, and that was just a gift to me. It was so beautiful. Um, anyway, I want to talk again a little bit about some of the other clinical models that we've learned it can be really helpful. A guy named William Breitbart, who's the chief of psychiatry at a big cancer hospital in New York, Memorial Sloan Kettering, developed a model called meaning-centered care for people near the end of life. And basically it's about hope. And you don't have to do this very structured 8-week model with patients to have it work. You can adopt parts of it. And basically the whole idea is this particular model was developed for people with advanced cancer with the goal of helping people identify multiple sources of meaning. And so you can do that when you're visiting your clients. What keeps you meaning now? What's still meaningful? You know, playing with my grandkids is just the light of my life. Or I still have the energy to volunteer at the local food bank. Or I can still, you know, visit with my sister on the phone each day, or whatever it is. What gives your life a sense of meaning, and being more fluid and flexible in ways to think about meaning. Elizabeth said that she has adapted a model of dignity therapy, which I'm so happy to hear that's a possibility for your program, because dignity therapy is a really cool approach. I know that's not a very, you know, scholarly description, but I think it's really, really wonderful approach to working with people. I had the opportunity to bring Dr. Harvey Chochinov to Portland a number of years ago to do a training for a bunch of us. He authored this. He's a psychiatrist in Manitoba, Canada. Delightful guy, also very, very funny. But he developed this model called dignity therapy, interventions for people at the end of life. And he suggests that, and he's researched this model a lot, that early studies show a strong association between things that undermine dignity and depression, or things that the strong affiliation between the undermining of dignity and rates of depression for patients, and anxiety and desire for death and hopelessness, versus if we promote dignity, that can help people reduce hopelessness, depression, anxiety, and the fear of being a burden. So his model really looks at that, and it's their brief individualized psychotherapeutic interventions designed to address psychosocial and existential distress among terminally ill patients. The model, if it's taken in its pure form, is a set of scripted questions, and you have someone who's trained in this model to sit with the person who is terminally ill, ask these questions, record it, and scribe it. And then again, the model in its pure sense is to take it, have the transcription written out, and then you bring it back to the patient to edit and correct any misconceptions, and then give it to the client to leave as a part of their legacy making for their patients, or excuse me, for their families. So it's very cool. It's part of legacy making. It's part of almost like a living will, but it's around these very specific questions. What I have found is that you can adapt your practices with these questions by using these questions. And you can be creative with it. You can use these questions. You can create kind of a living journal with them by writing down the answers to these questions. You can add photographs to it. You can do collage work with it. You can do all kinds of really creative things depending on the setting that you're working with and the capacity of your clients. But it's what we want to do is deal with the existential distress and reduce the notion of suffering. So some of the questions are, tell me a little bit more about your life history, particularly the parts that you think are most important. This next question I love so much. When did you feel most alive? And I'd like each of us to just think about that question for ourselves. When I think about that, there are very specific times I can remember. And I think we'd like very much to create more of those. You know, that's the gift of working with people with life-limiting illnesses, is it's a reminder to us that we too have a limited lifespan, even if we don't know what that limit is. So how do we use our moments of uncertainty to be more alive? So when did you feel most alive? That is such a cool question to ask your clients and to ask ourselves again. Are there specific things that you would want your family to know about you and for you to remember? You know, my two friends who've lost their moms recently wish they'd ask more questions. They talked to their moms a lot about a lot of things, but there was still more that they wish they had asked. What do you want your family to remember? What are the most important roles you played in life? And why were they so important to you? And what do you think you accomplished in those roles? It might be being a mom, it might be being a grandpa, it might be a pinnacle of somebody's career. It might be that you helped during a disaster. It might be something you never even thought of, but people play a lot of roles in their lives. What are your most important accomplishments, and what do you feel most proud of? And again, it may not be what you're thinking it's going to be, or the family's thinking it's going to be, but it's a really great way to explore one's history. Are there particular things that you feel still need to be said to your loved ones, or things you want to take the time to say again? You know, my neighbor's dad never had the ability to do that, but often we have unspoken regrets or things we want to apologize for, or just to reiterate how much we love and treasure them or how proud we are of what they've done. What are your hopes and dreams for your loved ones? What have you learned about life that you want to pass on to others? Again, that Pew study of, you know, live life, be grateful, you know, help others. You know, they're things that we might want to pass on to others. I love this one too. What advice or guidance would you wish to pass along to others? My dad said to me before he died, stop taking life so seriously. This from a Swedish immigrant who I learned that from. Maybe that was his lesson. Let's have more fun. Let's play. Let's not work quite as hard. Let's love life. Are there words or instructions you'd like to offer your family to help them prepare for the future? And in creating this record, are there other things that you'd like to be included. And when we come to our Q&A session, I'd love to hear Elizabeth's perspective on using this model in your practices. Elizabeth, I'm calling you Elizabeth Angela. Thank you. I apologize. So again, ways that we can really offer hope to our clients, again, as we already have considered, being present, not being distracted, being really, really present. And you know what that looks like. You know what that feels like when people are truly, truly being actively present. Giving accurate information presented in a compassionate manner, not false hope. So it isn't up to us to say, no, you're not going to die, but it is up to us to stay present and say, tell me more about that. Are you worried? What are you worrying about? Caring behaviors, just, really eye contact, sitting at the same level as patients, the basics that you all know. Giving people the opportunity to tell their stories and promoting dignity, whether it's to help them sit up in a particular chair. I had the opportunity to do a really fun thing yesterday. I live in a neighborhood where the author Ursula Le Guin lived, and their family has donated her house to become a artist in residence place for writers to come and spend time, which is really cool. And they had an open house yesterday, and many, many, many elderly neighbors went. And it was really touching to me to watch other neighbors help them get up the stairs, find them a chair, get them something to drink. These very basic caring behaviors that really promoted dignity. They were peers of Ursula Le Guin. They knew her as friends and as young moms together. But the fact that people wanted to make sure they had a place to sit, got up the stairs, were helped to get refreshments, those caring behaviors that mean so much, and it doesn't require that much on our part to be helpful. We also know that, am I stuck? There we go. Other things that engender hope are making sure people's symptoms are adequately managed. Again, depending on the role you're in, you may want to make a call to the hospice nurse or make a call to a visiting nurse if their symptoms aren't being well controlled. Fostering and developing connectedness, assistance in attaining really practical goals, exploring spiritual beliefs, all the things we've just already talked about. And then identifying personal attributes such as determination, courage, serenity. That physician that wanted to die with a perfectly clean house, my friend, one of the things she often did with her cancer patients was to say, especially if she thought she might not see them again, she would reflect back some personal characteristic that she really admired. You've really been brave. You've maintained a sense of such grace despite what you've been navigating. Or I love your sense of humor. Whatever it is, some comment that you want to make about their personal attributes that can be meaningful. And it doesn't always have to be so darn serious. And take the patient's lead, of course. You don't want to go in and crack a joke if somebody's crying, but, that's an extreme example. But, I have patients that are hilarious and I want to go with their lead. I had a patient one time who was so funny, and she was dying of a terrible disease. And it was when I was in a role where I could do home visits, and I went and said what I thought was my final goodbye to her. And she seemed very near death. And the next day, my phone rang in my office, and she said, Susan, it's Annette. I'm not dead yet. Could you come back? And I said, of course. But she was just so funny. Her husband was studying to be a mortician. So they lived upstairs from the mortuary. And she'd say to me, isn't that handy? And say, I guess, yes, it is handy, Annette. And other things, I'm sure all of you can think of examples in your own practices of people who can find lightheartedness. And so I think match them with their lightheartedness as appropriate. And we want to affirm worth by treating people as a valued individual. And then again, uplifting memories and life review. Why is this important? Well, I think it's so important for kind of obvious reasons, but by paying careful attention to their language, a whole lot of outcomes can occur. One is their care may improve, the meaning for the patient may evolve, patient professional communication will improve, and our satisfaction will improve. We do this work usually because it's meaningful, not necessarily because um, we're getting wealthy as a result of doing it or be other reasons, but there are a whole lot of reasons we do this work. But again, returning to why we do it is often a sense of purpose, a sense of meaning in our own lives. So doing this can be really meaningful as there's this sense of bidirectionality with our clients. I think it would be remiss if I didn't acknowledge that we too grieve in these situations. We too witness suffering. We witness certain situations that we can't fix or change. We watch people deteriorate, and sometimes that is incredibly painful. And I think that it's important to attend to our own warning signs and knowing the differences between burnout, compassion fatigue, moral distress, and grief, and recognize that it's okay to grieve. It's really okay to grieve when we lose our patients. I still facilitate a yearly day-long retreat for oncology nurses at OHSU because they rarely have the time or the bandwidth to attend to the loss of the patients that they have encountered. And so I think that's really important, but I also think it's important to recognize that we are resilient. We can continue to do this work as long as we're taking care of ourselves. And there may be times in our personal lives that make it harder to do this work. And recognizing that and maybe pacing ourselves and taking breaks can be really important. We want to recognize the long-term effect of grief. And I think the expression self-care has become a little bit shallow for a lot of us, especially since COVID. Oh, goodness, my Labrador has come home and is quite, I don't know if you can hear him, but he's rolling around wildly. I apologize. So the whole self-care thing, I think during the pandemic, we were telling healthcare providers to take care of themselves, and people would say, "What does that really mean?" And the other thing it suggests is that if you take a yoga class or go for a long run, as much as I think those are great things, it doesn't necessarily attend to the personal toll that this work can take. It also doesn't attend to some of the things that are broken in our systems, especially our healthcare systems that don't support us as well as they might. But I think attending to yourself is what I call responsible selfishness, meaning selflessness, in a selfishness responsibly. So you're not ignoring, your family or the rest of the world. You're taking care of yourself so that you can show up the next day. And that might mean taking breaks. It may mean asking if you can add a debriefing or some support through your agencies. Hospices are really good about having memorial rituals because they have a steady diet of loss, and their rituals are really important as a way of acknowledging what they've been through. So again, I think it's important to attend to your grief as well. And at the end of the day, our hope is to return with compassion, because compassion for yourself, compassion for your teammates, compassion for your clients and their loved ones. And again, we are often in a situation where clients and their families are navigating some of the hardest times in their lives, and they may not always find their own sense of peacefulness as they or great or equanimity as they go through this. And so if we can navigate it with as much grace as is possible, grace for them, grace for ourselves, that can be really helpful. And Arthur Miller says maybe all one can do is hope to end up with the least regrets. And so, again, I think doing this work is a privilege, and it gives us not only the chance to truly make a difference in the lives of others, but truthfully, if we're paying attention, it makes a difference in our own lives as well. It gives us a chance to have perspective on what's most meaningful for us and those that we love as well. And with that, I'm going to stop sharing. We've got ample time for questions. and want to open it up to whoever wants to add your own wisdom, your own thoughts or questions or challenges, any of those things.
Oh, good. Well, I've been waiting to ask you a question for weeks and weeks. Um, so, um,
You have my email. Can reach out anytime.
okay. And I almost interrupted you earlier, but I thought better of it. So, when you're working with a family that doesn't want to tell their loved one what's really going on, how do you navigate that?
Oh, that is a beautiful, beautiful question. And that comes up particularly when we're working with people from other cultures or customs who may not believe that it's appropriate to tell their loved one. In fact, they may think it causes harm.
Hmm.
There's certainly certain cultures that absolutely believe that by talking about it invites death. So if you're working with a family who is saying, I don't want them to know, I don't want them to talk about it. You may want to ask the question, do you think they already know? Because they usually do. Usually they do. And and I think if you can follow it with a question like tell me more about that, because usually they're afraid of something. They're afraid they're going to take away hope. They're afraid that they're going to cause more sadness. They're afraid that they might fall apart. And so if and sometimes families assign themselves the role of constant cheerleading. That if I keep telling mom she's going to be fine, then she'll be fine, or she won't be sad, or she won't feel alone or scared, or whatever it is. Whereas, oh, and I want to see what's in the chat here in a minute. Whereas if you say something, you can just explore it more deeply. You can explore it more deeply and just say, "Tell me more about that. What are your fears?" And I think that I think you want to be very, very respectful of the culture and the traditions. And I'm reading Kimberly in the chart saying I'm with the Navajo, and for the traditional, even speaking of death is taboo, it's been difficult to insert into conversations with patients that have a life-limited illness. And so I would say, and I want to hear your experience with that more specifically, Kimberly. I would say I think we need to be very, very respectful about that because we don't want to undermine the tradition of that particular person. And we don't want to come in as, quote, the expert. But there are times when it can be problematic or cause more harm, but I think we have to really take the lead of the patient in the family. Sometimes what I'll find, again, is if I'm meeting with the individual, um, I'll say, "What do you think is happening, or how are you doing?" And they'll tell me they're already thinking about it. They'll tell me that, I already know that I'm dying. Here's another example that I'll share with you. My dear friend, the oncologist, she was telling me about a Latina family that she was working with. The patient absolutely knew she was dying, and she was in her 30s, so she was young. The family absolutely made it clear that the oncologist was not to talk to her about that. And so we had to kind of broker this really hard place where family didn't want her to know. She already knew. She wanted to talk about it to the doctor and to me. She didn't want to talk to her family about it. And so, we were navigating this really hard, hard place. And ultimately, she did die without the family, talking directly about it. If you're working with a family that doesn't have that strong cultural taboo, for example, but rather feels like they're supposed to be the cheerleader, and you think that it might be useful to have a conversation and the client wants to have the conversation, then sometimes you can be the one to sort of open it up, and you can be the one to kind of say, gosh, let's say I'm working with Margaret, and Margaret has told me she knows she's facing the end of life and she wants to talk to her kids about it, but doesn't know how. And the kids are saying, I don't tell mom, you know, um, then you might be able to say, could ask Margaret, is it okay if we have a conversation together about this? And can I help you talk to your kids about what you're thinking about? And then that can open up a whole conversation. But that's different than having the cultural taboo, and the cultural competence that Kimberly's mentioning in the chat are really, really important. And oh, I love, love, love that you said a traditional healer can be included to really help with that. And Kimberly, do you mind coming off mute and telling us more about that? Kimberly, I'd love to hear more about your experiences if you're up for that. Oop,
We'll let her chime in if
if she wants to. Sounds
she
good.
might be distracted right now.
Might be doing something else. That's
Yeah.
fine. Yeah, I think the idea of a traditional healer, I used when I was really, really young and in college, I was working at a migrant health clinic in Central California. And it was really clear that we were the last stop for people. They would come if they were bleeding, our health workers, if they had a laceration or a broken bone. There was no way they would come if it was something else. And so it wasn't uncommon to have people come with herbal compresses, with strings around their wrists, having worked with curanderas before they came to us. And I remember as this naive college student, I said to somebody in the clinic, why don't we have a curandera working here? And it was a naive question, but it ended up being one that they took to heart eventually, not because I said anything, but they hired a curandera and it changed everything. Because then we could, because for example, a child with leukemia, leukemia in that tradition was considered a hot illness. And so you would treat it with cold foods, cold compresses. And what do we do with cancer treatment? Chemotherapy, radiation, those are considered hot treatments. And so we really had to navigate um, with great humility other education around treatment. But I sure wasn't the one to broker that. It was the traditional healers that could. So, what else? What else are you thinking about?
I know. I would love for anyone, let's practice some of that narrative reflection because I know that people have come to me and others about clients. So if you have, a particular client that you kind of want to put forth with Susan, please do so. Obviously, no personal information. Um, but yeah, it would be great. Or to hear stories, yeah, of things that people have experienced would be really good.
Louisa, did that answer your question?
It did. And
Good.
since nobody's jumping for it, I'm going to ask one more then and
Please,
take advantage.
please.
Um, it was, well, first a comment. It was really reinforcing to hear about the different types of treatment, behavioral activation, acceptance, commitment, cognitive behavior. Those are all things that I use every day. But sometimes I get folks that are really kind of stuck with oh, I wrote my word down, apathy. And it's just really hard to get that first bit going. Um,
Yeah,
I
yeah.
mean, they're here at at options for a reason, so they're probably more stuck than some others. Any other tips or ideas?
Well, stuckness is a tough one.
Yeah.
I think it depends, what you do with it is often dependent on your relationship with the client. I mean, is it
Mhm.
somebody you know pretty well? Is it somebody you've just met? Is it somebody that, I was mentioning my very, very negative chaplain. I have to dig deep to go visit her. I really do because I feel really stuck. And that I've tried to get brave and tell her that sometimes, and she gets really reactive when I say that, and so I've had to kind of then back up, figure out a different way into the story, figure out what does work with her. When I had my private practice and had the luxury of longer term relationships with people, I would often say, or not often, but if I had a client that I felt but that we were both stuck, I'd say, I'm feeling kind of like our wheels are spinning. I'm feeling a little bit stuck here. I'm wondering if you're feeling that way too. And that often would give way to a change of direction, because they'd go, yeah, I have, sometimes it meant I wasn't the right fit for them, but sometimes it meant there was something more important that we'd been avoiding talking about, or we needed a different approach, or whatever. But then there are going to be people that just stay stuck. And that may not be anything we can do a lot about. I think the fact that they keep coming is really important.
Heck yeah.
And sometimes at the end of the day, that's what you got to come back to is, well, they keep coming every week, so they must be getting something out of this.
Yes.
The thing that I think we don't always recognize that we give clients is we may give clients a caring relationship that they lack elsewhere in their life. Okay. We may, bring hope and compassion. We may bring presence. We may diminish some of their loneliness. But they may not be coming to do a lot of deep work. And that's okay.
Yeah.
That's okay. I remember back when I was a baby social worker, that was a long time ago. Kubler-Ross was really popular. And one of the doctors I work with literally wrote an order for me to go talk to the patient and talk about Kubler-Ross stages of loss and grief. That was in
Oh my
which
goodness.
I thought was pretty funny because I think he didn't know how to talk about it. Anyway, went in. She had no interest in talking about that. She wanted me to brush her hair. She wanted me to, get her water bottle closer to her bed that she couldn't reach, stuff like that. And the doctor was so disappointed in me, and I was like 25-year-old social worker and trying to prove myself. And, he was so disappointed in me. And he just said, why couldn't you talk to her? And I said, I tried to. She didn't want to. So that's the other thing we've got to remember that not all of our clients, they're diverse. They're very diverse. And some are going to want to talk about this. Some are not going to want to talk about it. But where you have the opportunity, take a risk, go in with some of these questions and see where you land. And again, they will let you know if it doesn't land. My chaplain reminds me every week that it didn't land and I'm backing away to something else.
Your words again are so reaffirming. Thank you so much. I hope some other people can take advantage of our time here with Susan.
Please do.
I'm seeing a lot of compliments for you in the chat about a great presentation.
Oh, thank you.
I'm trying to hold off, but I would love to talk a little bit about, I guess, I I'm an older adult behavioral health specialist, but my background is as a end of life doula, death midwife. And one of the things that I have experienced with working with people is the relief that I've noticed of like the direct communication, and that most of the times it lands really well, more often than not, like being direct with someone, asking those like questions is really it doesn't happen in their lives. And then also the assumption that people who are in these caring positions, like healthcare providers and people that work at long-term care facilities and caregivers, that they know about end of life and dying. And so navigating that, asking clients like what is your experience with your caregivers, because I think one of the things that we need to do is to have our own personal examination of our like relationship with mortality,
Oh,
and to
no.
recognize like how that changes the way we interact with people
Mm,
facing mortality. Um, and so, I
sure.
mean, as like a suicide prevention trainer, that's one of the things that we ask, in some of the trainings, like, what's your story around suicide? Because that's going to impact how you do an intervention with someone, positively or maybe negatively.
And
So,
I could not agree with you more. I couldn't. And your team is so lucky to have your insights because I think if we're reactive around death, it's going to be really hard for us to work with it. And as I mentioned, I think there will be times in our own lives where our own circumstances make it really hard to do this. When I was 30, one of my assignments in the hospital where I was working was the trauma ICU, and the person I was dating at the time was killed in a car accident. And my very first referral when I went back to work was to talk to a woman in the ICU, a young woman who's was pretty badly injured, and her fiance had been killed in a car accident, and nobody had told her. That was my first referral back, and I was like a walking zombie at that point, and I couldn't I couldn't do it. And thank goodness, somebody was watching over my shoulder and just said, "You're not taking that referral," grabbed it out of my hand. And her mom was dying of congestive heart failure at the time. So for a while, we just swapped assignments, because we still had to show up, but I could easily show up with women with congestive heart failure at the time. I couldn't show up in the trauma ICU. It was just parallel to my own story, and so sure taught me a lot about grief, that experience. It changed my whole career trajectory in some ways. But what I'd say is we have to examine these things for ourselves. And sometimes we examine it because it comes up close and personal like that. And other times, we're given an opportunity to examine it because of the work we're doing. And I would say it's important to not be afraid. It's important to go toward it rather than away from it, even though um, that can be difficult. And boy, with your suicide prevention trainings, that is critically important to look at that, because that's such a powerful, powerful end of life experience for people. We used to, when I was doing bereavement groups at Hopewell House years ago, we separated out loss through suicide because it was so different. It was so intense in the bereavement experience. So I think I really welcome what you just said, and the whole idea about giving ourselves grace. We aren't getting out of here alive, but we still live in a culture that's pretty death denying. And um, even if even if we aren't from a culture in which talking about death is taboo, the general population still doesn't talk about this very easily. We lack language, we lack um, safety, and that's another role we can sometimes play with our clients and their loved ones, is not being afraid to ask the tough questions. And again, remembering they're not fragile necessarily. And they welcome it. Like you started this before I went down on this long tangent, by saying, Angela, people often welcome the directness. Yeah. Other comments, questions? Love being here with you guys.
I'll comment and just echo what others have said, which is that this has been such a valuable discussion and presentation. And I'm grateful for you, Susan. And it's helpful to see your like sense of calmness and also your sense of hope modeled, because like you've shared, I think that those can be so essential in like providing that helpful presence. And yeah, I'm just grateful. And I also found a website about the dignity therapy. So I'll share that in the chat. It's very helpful.
Yeah, you can go to the training with Dr. Chochinov, which is really wonderful. It's not inexpensive, but again, I think, and Angela, was telling me she's adapted that model for training, which I think, and I, with my staff when I was at OHSU, I would just encourage them to use the questions as they felt helpful. It doesn't, the formalized training and the literal way of doing it is a little more intense, but or rather labor intensive rather, but the questions are fabulous. And thank you for that comment, Isabel, about modeling calmness, because every one of you do that every day. We don't always feel it.
Yeah.
I got feedback from I was in charge of this big thing in Washington, D.C. last week, and someone afterwards said, I love your leadership style. You're so calm. And I thought, are you kidding me? I felt like my hair was on fire. But evidently it didn't show gratefully.
Mhm. I like that. Hair on fire is relatable.
Mm. Other comments or stories you want to tell? I know each of you, if we were in the same room together and had all day, I bet you'd have many, many stories.
I think one of the things that I would love to talk a little bit about, get your insight, is we're talking about the good death a lot, and how that's kind of the quote that you had before, bringing up the one that you say you might not use, and that you might not die gracefully, a lot of the people that we work with, maybe in like substance use, treatment, people who are unhoused, just the more like marginalized, minoritized people, it seems unfair to talk about the good death, and not to say that we shouldn't work towards like what that means for them, but to have this like standard of what the good death is, it makes my work, and I see other people's work, feel more of that like moral injury and moral distress, that causes the burnout and us leaving these positions. I don't know if you have something to say.
Oh my goodness, I have so many thoughts about that. Your insight is so wonderful. Yeah, I think, and I'm going to look for this. I'm going to look for this, Angela, to send to you. I used a quote from Rachel Naomi Remen in a talk I gave a number of years ago to a bunch of palliative care people. Rachel Naomi Remen was a physician who wrote Kitchen Table Wisdom and My Grandfather's Blessings. She's done a lot of work with people at the end of life. And it was a quote from one of her books about something about we have this fantasy that the good death means everybody gets to die with all of their issues resolved, all their relationships, reconciled, people feeling loved, with all their symptoms managed, blah, 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 blah. And wouldn't that be nice? It's like dying in the middle of the night with no symptoms and no compromise, and I use that quote in a training with palliative care professionals because they really want that to be the case. And sometimes we can't do that. Sometimes people die horribly. Sometimes in the acute care setting, you see people die in an ICU without anything reconciled and with, going down despite our best efforts. And when you talk about some of your clients who, are houseless or still in addictions and, just all the stuff, I think it's really unfair to put that assumption onto their dying. And again, you said so importantly, we want to look at what a good death for them looks like because they may have very strong ideas about that. But the other thing is I think at the end of the day, we come back to what we do and don't have control over. And also, even as practitioners, and also come back to the client and trying to serve their best interest and to the best of our abilities, help them achieve their best death. Unfortunately, as you know so well, that doesn't always happen well. It may be death as a result of violence. It may be death as a result of an overdose. It may be death, because they're unhoused in any number of really, really hard circumstances. And in those situations, I feel like it's even more important to find ways to debrief with each other, to talk about the unfairness of it, to talk about the injustice of it, to talk about what's so painful, because it does cause moral injury. And the way that we stay whole is to try to find safe places to process it for ourselves. I give a talk every year for the ECHO project on social determinants of mental health. And I always start out with a photograph that is a shrine that was set up in my neighborhood for a woman who lived on the streets. Oh, thank you, Elizabeth. I see your question. Protect yourself and not take on others' energy. Oh, I would love that question. What I was going to say about this shrine was that there was a woman who lived in my neighborhood on the streets for years, and we all knew her. Did not know her story, but we knew her. And she just parked in front of our local coffee shop and was there every single day. We would all buy her coffee. We all worried about her when it got cold, all the stuff. And she, I'd see her every morning on my way to OHSU, and she would often compliment me on what I was wearing. And I would just think, I wonder what her story is. And she'd be putting lipstick on and I would talk to the people at the coffee shop who knew her really well. And I'd say, where does she go at night? And they'd say, she's on the radar of social services. She has somewhere where she sleeps and she's on their radar, but she wants to be here. And then one day she was gone. And this was several years into it. And I could tell toward the end, she was really kind of decompensating. She was, not engaging with us anymore. And she was talking to voices and, she was really, really struggling. And then she was gone. And everybody was worried. And the word went out and somebody found out that she had been taken to the hospital with an infection and died. And then this shrine popped up. And it was an RIP on a piece of slate and flowers and notes. And it was really touching. And I photographed it and I use it in that social determinants of health, mental health presentation every year because I drive through areas of Portland where there's a lot of people who are unhoused. And I always wonder how they got there. I always wonder their stories. I always wonder what happened. And, we know all too well that trauma is a big piece of that history. Substance use is a big piece of the history, mental health issues. It's complicated. It's really complicated. And then I'll also share with you a story about somebody I got to work with who, it was a couple of Christmases ago. I was still at OHSU. We were really struggling with staffing. And so I volunteered to work on the bone marrow transplant unit for the holidays because I had a bunch of young moms who deserved to have time off. And anyway, and at the end of the day, I love the clinical work anyway. So there was a fellow who was brought in from the streets and with a new diagnosis of blood cancer called lymphoma. And he was in really terrible shape. And it was his ex-wife and daughter who found him. And the reason he'd never gone to the hospital was he didn't know what was going to happen with his dog. And so they figured out somehow a plan for the dog, brought him to the hospital. He was very near death and he had a disease that was actually treatable. So I got involved with him and I remember the physician saying, well, this one's going to be complicated because he needs about a year of history and a year of treatment, and he's going to need somewhere to stay. And he can't be with a lot of other people because of his immune compromise. Anyway, through a series of minor miracles, he was discharged from the hospital into a single occupancy residence through the work of a whole lot of people. But the reason I tell you that story was that when he was brought in, he had a beard down his waist. his little elderly mom took the bus down to visit and begged me not to discharge him to the streets, even though I wasn't a discharge planner. She just said, my other son died of an overdose. My other son is in jail for dealing drugs. And so one of the things that I would do with this patient was walk the circle around the unit and asked him, how did you escape substance use? And he said, well, one day it just didn't give me the high it used to give me. But he had ended up on the streets that, oh, thank you. Thank you, thank you, thank you. I'm trying to keep track of this while telling you stories. The thing that happened to him was he was running an electronics business, and then COVID happened, and he lost his business, lost his housing, was living on his boat, lost his boat, then was living in his truck, lost his truck, and ended up on the streets, And the day that he was being discharged, I went to say goodbye to him, and he was clean shaven, sitting up in bed with a hat on, and he said, "Who knew that?" Getting sick could give me a second chance at life. I'll never forget this fellow. I mean, it was amazing. It was really amazing. And the last I heard, he was still alive and well and getting on with his life. Of course, that's the exception. It's not the rule for so many of our clients. Going back to the question of how do you not take on this energy? I think we have to develop ways, and I would love hearing from you, Angela, your thoughts about this. I think we have to develop strategies that work for us, and they change over time. In my experience, when I was new to this work, excuse me, I had a need to process it. I had a need to talk about it. I was able to identify who I could do that with. It was usually other colleagues that did the same kind of work. But I also needed to figure out how to not take on that energy, like you said. I used to be a runner, and there was a place that I would run to up in the hills above my house, and I'd look out over the river and kind of send these prayers out to the universe every time somebody died, and hope for healing for their loved ones and that kind of thing. I'm not a runner anymore, but I think as time has gone on, I've developed different boundaries around the work. The other thing, because I've been doing this work for decades, I've diversified what I do professionally. So I don't just do clinical work. I do some teaching, I do some writing, I do these trainings, but I also never completely gave up clinical work because it's the most meaningful and it keeps my heart intact and informs everything else I do. But I think if you can diversify what you do, maybe it's a different project or taking on some trainings or that kind of thing. And the other thing is having both people and activities that have nothing whatsoever to do with this work. I have friends who really don't give a lot of thought to this stuff, which is really helpful. and they bring a different perspective, because I think we can get a little bit of a jaded outlook, or at least a biased outlook, with a steady diet of this kind of work. And so having other outlets that are creative, that are fun, that have nothing to do with this kind of work, having friends that, make us laugh, all those kinds of things that can help us step back from it and not take on the energy. And also, I think if you've just had a really intense encounter with somebody where there's a lot of this end of life energy, figure out how to smudge yourself, for lack of a better term. Figure out how to let it go, whether it's to, take a long drive home with some beautiful music, whether it's to take a hot bath when you get home, something to just sort of smudge the energy a bit, and take a break from it. But I'd love to hear your thoughts on that, Angela.
Yeah, I was like, oh, I'm going to type. I'm not going to have enough time. So I think like this work is not individual work. Like it really has to be like a collective. Because if we do it just solo, like it's going to be really difficult. So having those people to process with, around your experiences and actually feeling your feelings and not compartmentalizing. I think that is like really damaging to, leave things and then be expected to like have that detachment or disassociation. But some of just like the rituals of, I really love like cold running water. So after a difficult time, I will just stand at a sink and, run the water and have that feeling of just like cleansing and releasing, or in a shower, but that water as that like moving it. So
A
it's
ritual.
not staying on me, it's just moving. I really, yeah. I think that's one of my biggest things, is utilizing the movement of water, and the release is really big.
I love that.
Yeah.
Others have ideas of things that you do?
I also or like, I guess it might be similar to your water technique, Angela, but it just made me think of being out in nature. And as I walk my dog daily, which is like the backbone of my well-being. And I walk alone and with my husband, and we look, especially right now, we look, point out all the interesting flowers. And we saw hummingbirds, and for the first time, I saw a baby hummingbird yesterday.
Oh my gosh, they must be tiny.
Like, it was like it was probably the size of like my thumb knuckle. And so, like, as you can tell, these things bring me so much joy and just like meaning to connect with nature. So I totally agree with you there.
Well, and I think that example is a really, really beautiful one of mindfulness moments, and even if you're walking your dog every single day in the same place, the world is full of surprises, delightful things you didn't notice before. My Labrador was chasing running water down the street the other day, and the UPS guy stopped his truck and was just laughing because it was so cute, and I think that remembering moments of joy in our own lives, that's beautiful. Really beautiful. I know we are out of time. You'll get, it looks like CEUs. And also, Lisa was asking for suggested other training topics. But I just want to say thank you for the work that you do, because it's such important work and so needed in the world. And